PowerPoint narrative. Introduction. Healthcare teamwork plays a pivotal role in patient safety, clinician resilience, and service effectiveness. Despite the well-documented importance of teamwork, siloed workflows, role ambiguity, and communication gaps present significant barriers to IPC. The radiology department operates uniquely, blending characteristics of both the operating room and emergency room, requiring interdisciplinary coordination at a high level. Given these factors, my research question is, can physician-led webinars improve IPC perceptions among radiology nurses? Purpose of the study. The primary objective of the study is to evaluate the impact of structured physician-led knowledge-sharing webinars on radiology nurses' perceptions of IPC. Specifically, we are measuring changes in mutual respect, role appreciation, and interprofessional collaboration. My hypothesis is that participation in these structured webinars will significantly improve nurses' perceptions of teamwork and collaboration. And this is the overview of relational coordination. Significance of the study. Healthcare is evolving and so are its challenges. In 2022, the U.S. Census Bureau reported that 18.3% of the U.S. GDP was spent on healthcare, and workforce demand was growing by 5.1% annually. There is an urgent need to leverage healthcare resources, which includes improving collaboration across health professions. The World Health Organization's framework for action on interprofessional education and collaborative practice emphasizes the importance of IPC in helping address these challenges by improving teamwork, efficiency, and patient outcomes. One major hurdle is fragmented healthcare systems. Siloed workflows and unclear roles make teamwork difficult. IPC helps break down these barriers, creating seamless collaboration across disciplines to improve patient care. Leveraging expertise for education. A key part of IPC is leveraging the knowledge of healthcare providers to educate one another. Interprofessional education allows clinicians to learn with, from, and about each other, strengthening their ability to work as a team. Structured mentorship and training programs ensure knowledge sharing that leads to better patient care. Why does this matter? Research shows strong teamwork reduces preventable harm, enhances clinician well-being, and improves patient safety. That's in Rosen et al. Structured collaboration models also improve communication and patient outcomes. That's Bolton et al. Research gap. But while IPC is well studied in ORs and ERs, it remains underexplored in radiology. This study addresses that gap by addressing how structured, physician-led webinars can improve IPC perceptions among radiology nurses. By strengthening teamwork and communication in the setting, we can drive better outcomes for both clinicians and patients. Research aim and objectives. Collaboration in radiology is critical, but barriers like communication gaps and unclear roles can make teamwork challenging. This study looks at whether physician-led webinars can improve how radiology nurses perceive interprofessional collaboration, focusing on mutual respect, role appreciation, and teamwork. To do this, we'll measure changes in nurses' IPC perceptions before and after the webinars, identify key factors that influence collaboration in radiology, and assess whether structured education helps break down professional silos. Background and literature review highlights. My literature search was conducted using PubMed at COH, and CINAHL through EBSCO. My search terms focused on interdisciplinary collaboration, knowledge sharing, teamwork, mutual respect among healthcare workers. I did not put limits on publications in terms of dates. My initial search yielded 6 articles from PubMed, 13 from PubMed at COH, and 26 from CINAHL. My table of evidence reflects the most relevant research for my study question. The link between teamwork and outcomes. Teamwork plays a crucial role in healthcare outcomes, and research confirms that strong IPC leads to lower patient harm, shorter hospital stays, and improved job satisfaction. Effective teamwork structures help clarify roles and improve communication, ultimately enhancing patient safety and efficiency. Competencies of high-performing teams. High-performing teams share certain key competencies, including adaptive coordination, active listening, and structured decision-making. These qualities contribute to stronger team performance, professional resilience, and better patient care. Bolton et al. 2021. Challenges in radiology IPC. However, radiology presents unique IPC challenges. Unlike OR or ER, where teams are physically present together, radiology workflows are fragmented due to structural and safety barriers. Additionally, communication gaps, often stemming from hierarchies and unclear role expectations, can limit collaboration between radiologists and nurses. Theoretical framework. This study applies the relational coordination model to address challenges in radiology interprofessional IPC. Core elements of the RC model are shared goals, shared knowledge, and mutual respect. Aligning professional objectives, understanding roles, and valuing each other's expertise are key to fostering collaboration. Application to the study. In this study, physician-led educational webinars served as structured interventions designed to improve interprofessional education, IPE, and enhance collaboration between nurses and radiologists. These webinars create an interactive platform for knowledge sharing, discussion, and mutual role appreciation, reinforcing the core principles of relational coordination. The hypothesis that physician-led webinars significantly improves nurses' perceptions of mutual respect, role appreciation, and IPC aligns directly with the relational coordination model, which proposes that structured interventions reinforcing shared goals, shared knowledge, and mutual respect can break down professional silos, enhance communication, and strengthen teamwork in radiology. Study setting. Location. The study will be conducted within hospital radiology departments where physician-led webinars are implemented as an IPE intervention. Participants will be a stratified sample of radiology nurses, ensuring balanced representation across different experience levels. This distribution allows us to capture a broad range of nurses' perspectives on IPC, and I'll expand on this in slide 13 in the recruitment process. Format. The intervention consists of 6 virtual live stream webinars conducted via Microsoft Teams over the course of 12 months with 1 session every 2 months. Each session lasts 1 hour and includes a Q&A segment, allowing for interactive discussions between nurses and physicians to enhance engagement and knowledge sharing. Survey administration. To evaluate the intervention's impact, we will use the IP Interprofessional Collaboration Scale, or ICS. This validated survey is given before the first webinar to establish baseline IPC perceptions and after each session to track changes. By measuring shifts in nurses' perspectives, we can assess how structured educational interventions influence radiology collaboration and teamwork. Study design and schema overview. This study follows a quasi-experimental pre-test, post-test design with repeated measures to assess the impact of physician-led webinars on IPC among radiology nurses. Participants complete a baseline ICS survey before attending any webinars, which serves as their own control. Then they participate in 6 physician-led webinars over 12 months, with post-webinar surveys administered after each session to measure changes in IPC perceptions over time. To analyze the impact, paired t-tests will compare pre- and post-test scores. At the same time, a linear mixed effects model, LMM, will track longitudinal changes, ensuring a thorough evaluation of how structured education influences collaboration in radiology. Sample size and power analysis. To ensure a well-balanced, adequately powered study, stratified sampling is used to categorize radiology nurses into 3 experience levels: less than 5, 5 to 10, and more than 10 years. This ensures a representative sample across different experience strata. The effect size is set at Cohen's DZ 0.5, indicating a moderate effect, with a significance level of 0.05 to minimize type 1 error. The study's statistical power is set at 0.80, ensuring adequate probability of detecting a true effect. Based on these parameters, the initial calculated size is 34 participants. However, accounting for a 20% attrition, the total required sample size is just 43 participants, is adjusted to 43 participants to maintain sufficient statistical power. Pre-test, post-test timing and platform. Surveys are administered at key intervals to assess changes in interprofessional collaboration perceptions over time. A pre-test survey is conducted 1 week before the first webinar to establish baseline IPC perceptions, and after each session, a post-survey is administered and made available for 7 days following the webinar, resulting in a total of 7 surveys over the 12-month study period. Surveys remain open for 7 days to accommodate participants' schedules. Responses are collected securely and anonymously via jot form, ensuring confidentiality. To minimize attrition, automated email reminders are sent during the response window, prompting completion. And there's the demographics survey. Recruitment process. Participants will be recruited through email invitations, flyers, and hospital announcements. Those who meet the inclusion criteria will register via a secure jot form sign-up form accessible through a QR code and recruitment materials. To ensure balanced representation, nurses will be stratified by experience level as stated, and this is the stratification process. Classification into strata. First, eligible radiology nurses will be categorized into 3 distinct groups based on experience levels: less than 5 years, 5 to 10 years, and more than 10 years. Then we'll do proportional allocation. Participants will be proportionally allocated, meaning that the number of participants selected from each subgroup will directly reflect the actual proportion of nurses in each experience level within the entire eligible population. For example, if 40% of eligible nurses have less than 5 years experience, then approximately 40% of the final sample will be drawn from this subgroup. Random selection. Within each stratified group, nurses will be randomly chosen from the eligible pool using a random number generator. Each eligible nurse will be assigned a unique identification number, and selections will be performed to minimize selection bias. Randomization method, as stated before, they'll be selected using an online random number generator, ensuring unbiased selection process. This approach will maintain equal representation, equal proportional representation across experience levels. Once selected, participants are contacted via email with study details and next steps. To account for potential confounders, nurses will be asked about prior IPC training, which will be included as a covariate in the ANOVA analysis to control for its influence on study outcomes. Measurement tool. The ICS is a 26-item survey that addresses radiology nurses' perceptions of collaboration with physicians. It evaluates three key constructs: mutual respect, and professionalism, role appreciation, and workflow integration. Response are rated on a 4-point Likert scale, strongly disagree to strongly agree, with reverse scoring applied where needed for consistency. Higher ICS scores indicate stronger perceptions of teamwork and collaboration, making it a reliable tool for measuring changes in interprofessional collaboration over time. ICS reliability and validity. The ICS scale has been shown to be a reliable and valid tool for assessing nurse perception collaboration. Its predictive reliability is demonstrated by its correlation with real-world collaboration trends over time. Additionally, it has strong internal consistency with a Cronbach's alpha of more than 80, confirming its reliability in measuring interprofessional collaboration. Before analyzing the intervention's effect, I can collect pre-test responses and run my own Cronbach's alpha to verify the ICS is reliable within this study. This step ensures the scale maintains its internal consistency when applied to the radiology setting. The ICS also has strong face validity, meaning its items are directly relevant to teamwork in radiology. For construct validity, it shows high correlations with established teamwork measures, such as the nursing work index, nursing and the scale and the other scale. To assess the short-term impact of physician-led webinars on IPC perceptions, a paired t-test will compare pre- and post-webinar scores for each nurse. This statistical test evaluates whether the change in scores is statistically significant. The degrees of freedom are calculated as n-1, where n equals 43 nurses, resulting in a DF, or degree of freedom, of 42. Basically, if the t-value exceeds 2.018, we reject the null hypothesis and confirm a significant improvement in nurses' IPC perceptions. If the t-value falls below this threshold, we fail to reject the null, indicating no statistically significant change. Repeated measures ANOVA, tracking changes over time. We're almost done. Why this, why this? Ethical considerations. And the rest.